Oh, we're very democratic.
Give me 1 sec. I have like 20 windows open.
I thought I was the only one. I couldn't get this right.
I think I have to go to presenting mode.
Aaron, do you want to? I'm going to put you a little bit on the spot. Maybe just ask you to introduce yourself and how it is you came to do this project, because I think that's interesting as well.
Yeah, sure. I think I have one slide on my background, so I can do that on that slide. I'm just gonna share my screen again. Can you see the slides? All right.
Yes.
Without my notes and everything.
Yes.
Yes.
Perfect.
Cool. I'm just going to get ready here. Yeah. So thank you everyone for coming today, and so I suppose for this presentation, I'll be speaking about the racial justice report that we published. So I co-led this project with Miriam Gavin, who I think is in the room with you all today, alongside the Immigrant Council of Ireland and obviously the Trinity Faculty of Health Sciences EDI group. And this project is obviously funded by the Trinity Equality Fund. So in terms of my background, I qualify as a pharmacist at Trinity. And then I went on to study a master's in comparative social change in the Department of Sociology at Trinity. So I've spent about 7-8 years now at Trinity. And I, over the past year, also served as co-chair of Faculty of Health Sciences EDI group. And I also undertook a migrant leadership academy program with the Immigrant Council, and that's how I kind of got involved, I suppose, in the racial justice and migrant activism kind of space. And currently I have relocated to London to initiate my doctoral studies. So I'm currently based at UCL, but I'm still very much in touch and involved in the EDI work with my colleagues back at Trinity. So in terms of how I got involved in this project, I think I've one slide later on about the various articles that were published, which articulated the experiences of racism. I actually wrote one of them myself, and it was probably the first article, as far as I know, the first article that kept the unique experiences of healthcare students in Ireland, and I'll talk more about that later on. So project team members, we have people from the Faculty of Health Sciences staff and students, and obviously my colleagues in the Immigrant Council as well, working on this project. And acknowledgements, obviously, students who participated in the convening. And this project is really for them and about them, and other various people who supported us along the way, including Phil, who is in the room today, and the Equality Office, obviously, who funded this project. And the report is now available on Tara Open Access. So if you want to have a look, it's up there. And I think Lena mentioned the report has been circulated to heads of schools in the faculty anyway. And just to highlight that, this report was published on the 12th of October. And within probably a month and a half, this is the third time I'm presenting it. So there's great interest really in the work that we're doing. So I've presented the report to the Pharmacists Legal Society of Ireland, who was very much taken aback by the findings and are willing to do something about it. But if anything comes out of it, I don't know. We'll have to see, I guess. And also I'm in touch and connected with the UCL community here in the EDI space who wanted me to present the report as well. And that's coming up in December. So I think I might just skip this slide, but this is basically a background of the I suppose the baseline of racism in Ireland. 1 in 8 people in Ireland are from a migrant background. I think that's quite important to bear in mind, that our society is very, very diverse. And when we talk about reporting of racism as well, if you see the last 2 bullet points, only 1 in 8 people who experienced racism reported it to the Gardaí, and 40% of international students have witnessed or experienced racism, with only 5% reporting it. So the figure 404 reports that's gathered by Irish Network Against Racism in 2021 would have been a massive, underreporting. And we know that already, in terms of the history of racism and distrust in authorities and things like that. But, that's sort of a background information. And I suppose another thing to bear in mind is the various obligations Trinity and the Faculty of Health Sciences have in terms of making sure students and staff don't experience any forms of discrimination. And these are the legal obligations, as you can see on the slide, and different policies, reports, and statements made by the School of Medicine, and also some upcoming strategies and reporting, things like that. But unfortunately, there have been numerous reports of racism directed at healthcare students at Trinity. And this spans microaggressions, bullying, physical assaults, sometimes sexual assaults, and perpetrators include patients, colleagues, academic and clinical staff, etc. And here are the 4 articles, 5 actually that I mentioned. And I wrote one of them, which was the prescriptions and prejudices, and that captured the experiences of pharmacy students. And I should also mention that all 5 articles here are about Trinity students, across medical, nursing, pharmacy students. So that I think that's important to bear in mind as we talk about racism in Trinity and the wider higher education sector. And in terms of the project goal, then really this project is to develop racial justice in healthcare education by centering the lived experiences of minoritized ethnic healthcare students. And obviously this is not a commission project. What we're trying to do here is to create a platform for students to talk about their experiences, and hopefully this report that we generate from those conversations then can be used to inform strategy, policy, education, and research directions. But obviously, this is up to people in power to decide whether or not to take this forward. And I'm not going to go into details here, but basically we did a convening where we had a few keynote presenters who were our racial justice experts in the field, talking to the students. And then we had a focus group setting where, students can discuss racism in a safe environment. And now we're currently basically, disseminating the findings and the report to various authorities. And that's ongoing. And in terms of the convening, then we had 11 students, all undergraduate, most of whom were women, which is a very interesting observation in itself. Why weren't men coming forward? Or, maybe women experience more of this sort of discrimination. We had quite a diverse pool of participants from medicine, nursing, pharmacy, a mix of Irish and non-EEA nationalities as well. And in terms of ethnicity, almost half of the participants were Black, and the other half, almost half, were Asian background. And I suppose in terms of the findings of the report, then the overarching theme is that, students think that they have the experiences that they have because they are not white. And that being not a white person has sort of shaped their experiences in the healthcare education sphere, and that the experiences of racism is very much complex, multifaceted, and harmful, and in terms of their well-being and self-esteem and welfare and so on. And so we structured the report across, along the lines of institutional racism, interpersonal racism, and also internalized racism. So in terms of the institutional structural picture, there is a consensus that the support and reporting systems available to them are very, very underdeveloped, and it's very complex to navigate. It's very bureaucratic, very fragmented and unclear, especially when something happens on the clinic, in the clinical side. Who do you go to then? Is the site responsible for that, or is the college responsible of that? And if a student is paid to conduct their placements, that introduces a lot more complexities into this, into the picture, because they are then protected by employment law and things like that. And also some of the students were actively discouraged from raising concerns, which is saddening and concerning to hear. And there's also a consensus that there is a lack of accountability and transparency as to how reports are handled. What kind of pathways do they go through, and who are handling them, and what outcomes actually come out of it. And there's no follow-up from a school in the faculty on what happened to students who experienced racism, and even asking, are you okay? And then the story just sort of spread among friends in the class without proper properly addressing it. And that sort of lack of accountability has fostered a culture of distrust almost in authorities, where incidents are not effectively addressed, nothing was done, and as a result, perpetrators often don't face consequences. And there's also a lack of diversity and representation at both the staff and students level. And students have articulated that, at the top levels in a university, there really isn't that much representation within the faculty. And I know, in a school of pharmacy, there aren't really anyone teaching the clinical side of things. Even though there are, staff members, ethnic minority staff teaching the science and pharmaceutical chemistry side of things. But it's very interesting to see that there isn't really that much diversity within the clinical space. And in terms of students, they are quite disengaged from student leadership opportunities, because they thought, I wouldn't get voted in, because obviously the student body is very wide, and they just had this idea that even if they put themselves forward, they won't be supported. And mind the gap, and we have talked about this a lot already over the past few days, in terms of inequitable entry into healthcare courses, and also in terms of clinical exams that are often unblinded, and how students can be treated unfairly in those situations where it's not anonymous. And also in terms of social capital, let's be honest, the health sciences space is quite small, and a lot of our students would have had parents in healthcare systems who can help them to navigate through different pathways and know where the good opportunities are and things like that. And these are the things, the social capital, that our international students. Sorry?
Further research in the future. It's a bit like money is in the ground, to take it 20 years ago.
Keep going. I've muted them there now.
Yeah.
Sorry, Aaron.
Everything all right? Yeah. So in terms of curricular deficiency, again, this is something has been brought up time and time again, in terms of how the curriculum is very often centered on male and white bodies, especially, which is especially obvious in dermatology lessons, for instance. But some students have mentioned that individual lecturers themselves have made it their business to kind of, improve the curriculum and making it more inclusive and diverse. Interpersonal racism, they often manifested in the form of microaggressions, where students, were told things like, midway through a presentation, there will be a comment on your accent, what's your real name and where do you come from, and things like that. And this is quite unique to the healthcare setting, I think, in terms of racism coming from the patients. The students have mentioned that the atmosphere in hospitals are, generally more toxic, and that, they have experience of being bypassed, ignored, or spoken over, or refused to be seen by patients, and that there is a preference for white and or Irish healthcare colleagues. And when they experience, racism, then it sort of comes down to their own judgment as to how they deal with it, because they have to balance, their duty of care for the patient with their personal safety. And a lot of the racism that came from the patients were actually from, patients from vulnerable groups. including patients who are struggling with addiction or patients who, for instance, had dementia. That was in one of the newspaper articles where the student was sexually assaulted by a patient who had dementia, but the staff just shrugged it off and saying, they had dementia, they didn't mean it. When the patient comes first, then, you suppress racism, and how do you actually address that effectively in clinical settings? And academic and clinical staff, you might be happy to hear that students generally feel that, academic and clinical staff are supportive, but there are a few instances of bullying, race-motivated bullying, resulting in a student taking a year out. And again, concerns around implicit racial biases in clinical exams. And students, there is a culture of division apparently within the School of Medicine, where it was white Irish versus international students, and they felt exclusion by peers, where class rep often shared information only with Irish students, but not with international students, and that there were casual, quote unquote, racist comments by students towards minoritized ethnic groups. And these are the students who are training to become healthcare professionals who will be dealing with these patients in the future. And I think that's a very serious issue to address. And internalized racism, then, obviously you live in a society that's racist and, sexist, ableist, whatever, and you inevitably are going to internalize some of it. And students felt that the experiences of racism have made them accept less and reach out less and eventually achieve less. And it sort of became a part of who they are in terms of, not being taken seriously. And, that's just, their experiences that they can do nothing about it. And passive acceptance of racism, unfortunately, because things don't get resolved, they felt like, the only way to deal with it is to accept that this is the way it is, and there's nothing you can do about it, which resulted in, sense of helplessness, alienation, which then impacts on their mental health. And how they deal with racism, usually they don't do anything about it because they think it's not worth it. But they do acknowledge that, immediate acknowledgement and offer support from staff and students who witnessed incidents of racism is very important. If there's nothing in place at all, just having the people asking them, if they're okay and acknowledge the incidents would be very helpful. And that demonstration of solidarity is very much welcome. And not reporting it, they obviously, as I mentioned, there is this whole issues around systemic racism and lack of accountability. So students often feel disillusioned, and there's a sense of distrust in the systems, and they feel like in reporting these incidents can make them sometimes relieve the trauma, and it is a very much emotional labor to do that as well, apart from trying to navigate the whole structural complexity around reporting. And there's a fear of backlashes as well. Obviously, when the racism comes from patients or from senior staff members, then, how do you actually navigate that space? And a student said that, I reported my incidents, but they weaponized and used it against me. And this student actually had to take a year out, not by their own choice. So lots of work to do. And so students also articulated things that should be done by college. And we acknowledge that every action has to be centered around collective action, intersectionality, accountability. And obviously, it's very much about the students. And, systems change, culture and policy changes are needed to achieve that. And so we came up with 10 recommendations. I'm not going to go through all of them in detail, but
sorry, I'm not sure how long the presentation is. We're a bit over time. If you just
sorry, I can just sorry about that. So accountability, as mentioned, reporting mechanisms, support for the victimized, and promoting leadership, at both staff and students level, and trying to diversify the faculty, promoting curricular change, having open dialogue about racism, investing in research capacity, racial justice training, and also preparation for clinical placements. And I should also mention that this is not just for the ethnic minority students, it's also for other students and staff who are allies, who we need to engage to push this work forward. And I suppose just coming back to the one of the previous slides I presented, these are the obligations and these are the policies and these are the commitments that Trinity, the faculty, the schools, and have agreed to commit to. I suppose now that we have come out with this report, it is really up to you then, the people in power, to decide whether or not to do something or not to do something. And we'll be watching. I will be watching anyway from UCL. Anyway, that's me. Thank you.
Thank you very much, Aaron. That was really a great summary. Thank you of the report, and appreciate all the work that went into it. It's no wonder that the report has got so much traction. I think you just, it's so sincere and direct. I think it speaks for itself so well. So we won't stop. I think at this point we'll just maybe press on, but maybe hold on to you if you can, Aaron, for a discussion at the end. And we'll just move on here with Phil, who I think has gone a little bit as well to share. And Phil is co-chair of the race then. Or you're going to introduce yourself.
No, I'm just asking you if you will apply to me. Yes, so Lorraine Leeson is the Associate Vice Provost of EBI in Privacy, and she co-chairs this right that we want to do with myself. So next slide, please. So if we think about Trinity, its 2025 strategy has as its first goal the need to foster an ever more diverse and inclusive student community, and also to enrich and expand our global network and to be one Trinity community. And the Trinity values expressed in these strategies, things like inclusive pioneering, a responsible, inclusive and collaborative, they presuppose a welcoming of collaboration with and responsibility towards racial and ethnic diversity. Because after all, university will be neither pioneering nor inquisitive without working across national and racial boundaries. So while the strategy doesn't necessarily mention racial and ethnic diversity, and to date we don't actually have any data to systematically track racial and ethnic diversity among all grades of our staff and population, national and international indicators tell us that it's extremely low across the higher education sector and must be addressed. So obviously it's become a prerequisite for any large institution or academic institution to be aware of its institutional culture and what pervades and regarding race and ethnicity in particular, as it kind of impacts directly on the personal as well as the professional lives of those who actually try to inhabit the same academic space, but are perceived or treated differently or seen as different. So negative attitudes, both implicit and explicit, surrounding race and ethnicity mean that academic institutions can be less than encouraging environments for academics and staff from minority ethnic backgrounds. And the ability of academics to succeed and reach their potential may be frustrated where HEIs fail to provide a supportive environment for career development. And Trinity is not immune to these challenges. So the Racial and Ethnic Equality Working Group was established in 2021 to provide a framework to oversee the development and implementation of an action plan for Trinity College Dublin on race and ethnicity, so as to ensure a safe and empowering environment for all students and staff, and a commitment to eliminating discrimination in policy and practice is actually embedded in European and Irish legislation. So things like the Race Equality Directive from 2000 and also the Public Sector Equality and Human Rights Duty for 2014. So the work of the Race Ethnicity Group will actually support this. So the terms of reference set out 4 meetings per year. The group will identify the structural barriers that need to be addressed and any themes and issues that need action. It will prepare a data and research informed action plan to tackle race and ethnic equity or inequity in the university. Data collection will include qualitative and quantitative methods, so things like focus groups, town halls with staff and students. But it will also interrogate what data categories are developed and find ways also dealing with sensitive data, which will also be part of the work of the group. And then this group feeds into the Trinity. If you could go back to the second. It'll feed into the Trinity EDI strategy and action plan overall. It'll advise the EDI unit on questions of racial and ethnic equality as and when required. It will liaise with Trinity staff and student groups dedicated to working for racial and ethnic inclusion and against discrimination. So things like the Athena Swan Intersectionality Group, Trinity Inclusive Curriculum, the Widening Participation Group, and also the Trinity Colonial Legacies Project. And then we also hope to communicate and actively promote the work of the group on a college-wide basis and to the whole college community. Next. So membership of the working group then is broad-based across college, and it's chaired by, as I said, Professor Rena as Associate Vice Provost of Equality, and by myself as coordinator of the Black Studies elective. And as you can see, we've tried to ensure that the representation is as broad as possible and that all groups are represented within the group, both at staff, student, professional level as well. And I think I mentioned already that the only group that isn't represented is I suppose I don't know how to describe them, auxiliary staff or catering staff, orders, we haven't been able to interact with them yet. And I think they're an important group that needs to be also included. So for the purposes of today and for Rena's work, I want to just look at the focus group work that was done in 2021, which has informed our report. It has gone to the executive officer group, the EOG, and has also been signed off by board. And actually at around 1 o'clock today, I got a message to say it's gone to the printers. So it hasn't been published yet. So that's why we don't have copies, unfortunately, to review. So following the terms of reference that were developed for the group, we decided that a process of engagement was necessary to elicit the experiences of those who self-identify as part of a race or minority ethnic / racialized group, including racialized religious groups, and to determine the understanding of race and ethnicity as potentially kind of deleterious factors on the part of the wider college community. And this, it was hoped, will provide significant data then to the race ethnicity working group, as well as a kind of a jumping off point for constructing an effective action plan. So in total, 9 focus groups met in summer 2021, and each comprised a range of representatives from across the staff and student community. Interestingly, it was the height of summer, the end of July, and we had over 80 people sign up. So it did suggest that people wanted to engage on this issue. The focus groups were qualitative in nature, and the participants who took part were not identified by name or by their college role. And again, interestingly, people got in touch with me privately who suggested that their roles within college didn't allow them to take part in an open forum on a matter like this, but they did have concerns and issues, which was interesting at the time. So, as I've said, the report is not published, and given time restraints, I'll just bring you through some of the main relevant findings, which reflect much of what we've been discussing here today. So a consistent theme running through the focus group discussion was the point that Trinity has been doing lots of positive, proactive work on the issues of gender diversity, and it was suggested that approaches to gender equality are actually increasingly monitored. However, participants in various groups suggested that college needs to mainstream and model race and ethnic issues in a similar way to work in progress regarding gender mainstreaming. And there was a bit of a tension there about the amount of energy that has gone into gender mainstreaming. Next, Rena. It was suggested that Trinity should ensure that administration changes that occur over time should not impact on the strategic message of broad diversity and inclusion strategies, and that college needs to ensure that issues like race and ethnicity do not end up on the back burner, depending on the priorities that different administrations have. And I think this came out of the fact that we were in the process of changing administrations during the time that these took place. So I think it was just a concern that it might fall down the list of priorities. Furthermore, the point was made that those who are best positioned to inform the debates on race, ethnicity, and equality have to be heard, and their voices have to form part of any strategies that college will develop on these issues. Next thing. So it was widely recognised by the groups that developing innovative approaches to understanding race and ethnicity in Trinity will require structural change, and college needs to look at the typography and the landscape of the university in this regard. Participants referred to how financially dependent Trinity is on attracting international students to the campus to study, and that the experiences of some individuals are much less positive because of their backgrounds, their phenotypes, and they felt that Trinity should be doing a lot more to assist students who may have had adverse or negative experiences. And a range of students described how they felt the mission of support from college, both prior to arriving in Ireland and also while living and studying here, was actually crucial to their well-being. And participants advocated for an approach that recognised that experiences of race and ethnicity, as well as other dimensions of diversity in Ireland in general, and in college in particular, are different to other global models, and that we ought to be seeking to understand and negotiate those unique patterns and develop strategies that are designed to meet the Irish context rather than merely adopting models from abroad. So that was a really important point. Next one, So the importance was emphasised of having visible representation in both staff and student groups. And equally, participants claim that staff need support to be able to understand and negotiate the challenges that present in teaching and lecturing to diverse ethnic and cultural groups. And participants want college to do more to assist individual lecturers and students to understand and deconstruct some of the barriers faced in the educational environment. Next one, Lisa. So crucially, contributing to the lesson that people can be apprehensive and fearful about raising issues connected to race and ethnicity. Participants suggested that feedback eventually would arise around uncertainty as to how these topics might be received and reacted to. It was suggested that as Trinity seeks to attract more international students and to build international partnerships, it's crucial that it seem to be as responsive as possible to issues that could arise around these issues related to race and ethnicity, and also to be proactive instead of being reactive in its actions on race and ethnicity. Participants also suggested that sometimes conversations around race and ethnicity can be difficult, but that these difficult conversations provide opportunities for rich solutions, suggestions, and ideas to develop. For innovative ideas to emerge, it was suggested that it's crucial that Trinity be open to the possibility of challenge and questioning on its approaches to race, ethnicity, and broader equality issues. And an issue raised again during conversations was how complaints are dealt with and the level of confidence felt by students in making complaints. And some feedback expressed low levels of confidence in terms of the systems the college has for dealing with complaints and supporting students. Next one. Am I on the right one? Okay. I'll skip to the last one. Yeah. So everything that came out of our findings actually mapped very closely and was in keeping with the 2021 HEA's report. And Aaron's report that we've just heard, I think, is very similar in its findings. The race equality report did an online survey of 3,323 HEI staff nationally, and approximately 10% of the total number of HEI staff in the country. And this report found that across all groups, the majority agreed with the statement that race inequality exists in Irish higher education. And while there was an awareness of policies on race and ethnicity, it was often noted by respondents that these are embedded and less visible within broader equality policies, such as dignity at work and mutual respect policy. Some individuals also remarked that there were more policies relating to gender than ethnicity, and that maps on very closely with what we found. The respondents also noted that if policies exist, there's no real implementation of these policies and no visible outcomes in the staff body. And senior leadership and HEIs were most commonly identified as the group that were most critical to the process of improving race equality in higher education. The report has made recommendations across 8 thematic areas: supporting diversity in staff, supporting diversity in student recruitment, making race equality policies transparent, reporting mechanisms, awareness and training, fostering diversity in HEI's leadership and data collection. So a final point before I conclude then, I will just say that note that our own recommendations in our report are very much in line, and our themes map very closely with HEI's report. And so I think it will be benefit to all of us here to make use of these 2 reports as a means of informing the discussion going forward. Thank you.
Yeah, thank you, Phil. As you say, you know, a lot of the same themes there as Aaron found in his, but we might come back to that a little bit later, because yeah, it's a lot to think about there, and you know, it'll be interesting to see the work of the working group as it comes along. But again, hopefully we might have a chance to delve into that a bit. I think we'll push on in the interest of time and let Rena get her stuff out there so we can see it all. Yeah, that.
We'll do the bio break. So thank you, and I'm gonna zip through some of this. I wanted to first, acknowledge, it's important to acknowledge what people have contributed in terms of their courage and work, and the students who participated, and the leadership of those who work with them. I think it's very important that be acknowledged, recognized, because of the experiences that individuals have to then give more toward helping us as an organization move forward, and to acknowledge your work as leadership with Lorraine, because it's not just a report, it's a labor of love and courage, so thank you. So I'm, oops, wow, so sensitive. So I'm gonna go.
Very sensitive.
This one. I want to go back to the report that Aaron presented and talk about the buckets. He framed those for us, and I'm going to go through actually each one of these when we think about these as areas of opportunity, very much focusing on not leaving information like this on the table as an opportunity, because it will be a lost one if we leave it as such. So why take this on? And I wanted to, Aaron took the argument from the legal framework, and I want to suggest that this is why. Because as an organization, for someone who comes from a different place and space, and who has actually experienced this organization in a very rich way and has really learned so much about the openness and the commitment here, the public-facing view of being the leading university with an unparalleled reputation for excellence, the 8th most international university in the world, this is the values argument that I want to make, because Trinity can and should lead the way in this work. For me, the question is not if they begin this work, it is when we begin this work. And there is no more important work, I think, that can be done in health professions education than the work to dismantle structures of racism. That is the strongest argument. There are many others. The population of Ireland is changing. These are data from the report that was the census report in 2016, where more people have tried to now reflect their ethnicities and speak about their identities. the population is changing. These are the growth bars of those who are identifying their ethnicity. Medical students in Ireland are changing. Irish students making up only half now of those studying medicine across all 6 schools in the country. The greatest growth from non-European Union students. And these are the voices of our learners, right? Aaron put them in some of his slides. Imagine if these just stood here for us to just look at. Would we want this to be their experience? No, none of us would. None of us would. So there is no shortage of reasons for why we need to do this work. And I hope I can convince, I know that I'm preaching to the choir here, but this is, you know, we do not want these to be the stories. So I'm going to zip through a little bit because again, I feel like we're preaching to the choir here. The concept of structural racism. It is not about, you know, our internalized forms of perception that have been developed and sustained and supported by what we hear and the lived experiences around us and the way policies work. But the idea that at the structural, institutional levels, we have to dismantle systems systematically in order for us to have enduring change. So I want to steer us away from the concept of equality and this idea of everybody should get the same thing. I'm providing every group with the same thing. And we have to move to an equity framework because of the biases in the structures and institutions that have led to where we are today. We need much more fairness related to the unbalanced conditions. We need to proactively identify and eliminate barriers. And we need to be very conscious of tailored resource distribution and allocation to guide the work we do in dismantling racism in health professions education. But why equity as a framework? Because there is limitless data that having diverse, inclusive environments leads to better approaches, better solution generation, better climate, and better engagement. And in health professions, where we know the issues are consistently complex and not simple, we need diverse, inclusive environments to solve the problems. It also, in terms of an equity framework, allows the Faculty of Health Sciences here at Trinity College to systematically deconstruct these practices, reflect on the fact that the population is completely changing and those are the people we serve. And then the organizational mission, which actually states that Trinity College to embrace an ethos of social responsibility and accountability, dedicated to meeting the healthcare needs of the national and global community. Very aligned. That's the equity framework. So how does racism operate in medical education? The report from Aaron and his group really exemplified the levels of how racism operates in medical education. From the learning environment in which people have to live, to the formal and informal or hidden curriculum, to the support and opportunity structures that are put in place. There, it is rampant. It is everywhere in medical education. So let's go back to that slide that Aaron talked about. I'm going to go through each one of these. You'll see me sort of parse through the curriculum assessment bucket, faculty, staff, policy procedures, and fostering a culture of inclusion. And here are some broad recommendations. They are not meant to be comprehensive. We could spend hours on each one of those buckets, but I just wanted to leave with some thoughts and ideas and stimulate discussion. So from the report in that bucket of curricular and assessment, it was this idea of content and pedagogy as it relates to the curriculum. And then to really think about how does one address assessment biases and inequitable attainment gaps. And the college is on this process of a process of curricular change. And the questions that I think the committee needs to consider from the outset, it has this beautiful path to looking forward. And now's the time to do it, as opposed to saying we build it and then we tinker. This is the moment. What are the guiding principles related to racism and bias that the curriculum of the next century or the next 2 decades is going to address? Is it going to be an evolution? Are we going to tinker? Or are we going to revolutionize education as it relates to racism and bias? Are we going to have an anti-racist pedagogical approach, which is a methodology of making system oppression visible, naming it, recognizing our role in privilege, what does privilege mean for us, naming it, and helping our learners who are going to be these amazing physicians or health professionals of the future take on structural inequities and with as much vigor as they're going to take on the next breakthrough in scientific research. Right? Is the process of curricular reform going to be representative and inclusive and transparent? Who is at the table? Is it just faculty? Is it the most promoted faculty, the senior leadership? Who else is represented there? Whose voices are not there? Is the design of the curriculum related to racism and bias integrated or standalone? Philosophically, do we want it to be 3 modules every year? Do we want it to be built into everything we do whenever the opportunity presents in the new curriculum? This is not a retrofit, this is a new curriculum. What's the breadth and depth that we're going to take this information to? Are we going to have things that are required as part of what we teach all our students? Or are we going to have electives? What are the competencies? Those are the guiding principles. What are the competencies related to diversity and equity inclusion that are going to be expected of all our graduates? One option to look at is the very newly published DEI competencies from the Association of American Medical Colleges. Again, not an American system to plug on here, but they have some competencies that are very well sort of described. We don't have to reinvent the wheel. And then are we going to say that one of the competencies is naming and challenging the health effects of structural racism, the concept of a structural competency as a driver, as much as it is a driver to be competent in eliciting a patient history or completing a physical exam. In terms of content then, so that was sort of broad, and then drilling down, the recommendations are things like, what is the definition of race and racism? What is intersectionality referred to? What is bias? What is privilege? What are the structural determinants of health? What's the history in this context of bias and racism in healthcare? Not America, not somewhere else, in this nation. How can we think about how it manifests in terms of access, patient experiences, their healthcare outcomes, their trust with the system? What's the impact of structural determinants of health on the health outcomes of the people we serve, the communities, and the population? Naming racism as a structural determinant of health. And that is not only a sort of content area, but it is an actionable area with equity-focused skills. What does a learner in health professions need to know is their responsibility related to the structural determinants of health? Do I expect them to go out there and change the world? No. But what is their responsibility when they're meeting a patient and they have not thought through what are the enablers, facilitators, and barriers to then achieving full health? How does critical consciousness play a role in this? I've said a lot. Lena will send all these slides up, and I've put a lot of citations because I think there's so much out there that we can learn from. We don't have to know it all. We're all learning. But the concept of how we think through the social, cultural, historical context and interrogate social problems through a lens of awareness, right? How do you take a social determinant, structural determinant of history as part of the patient history? Tell me about your housing. Tell me about how you get food. I want to know more about how your children experience their learning life. I mean, we talk endlessly about other stuff, but that's the biggest barrier to patient outcomes. How are we going to begin this concept of enhanced representation, not just in images, which is important because visibility matters, but every clinical case? We're constantly teaching through clinical cases. How are those cases representative of the population that our students are talking about seeing in the clinical environment? What about our simulations? What about our standardized patients? How do we bring in the representation so people develop connection, as opposed to, oh my God, the person looks really different than me and I don't know what to do now? How does it become part of the fabric of teaching? How is race addressed in curricular and assessment materials? There is tremendous literature out there that we can turn to, and we can look at our curriculum as we design it. Semantics. Are we conflating race and biology in our materials? Are we talking about prevalence without context? In the US, this constant concept about Black people have more asthma than white people, when actually housing and exposure to allergens and pathogens is responsible for the vast majority of asthma in Black patients because of housing inequality. Race-based diagnostic barriers, the concept of associating disease with race, right? So Black people in sickle cell is one that we do all the time in the US. Every case they've ever been learning about sickle cell is a Black person. Whereas it's actually a genetic development in people who have come from malaria prevalent regions. It was actually a protective gene. Pathologizing race, right? Oh, you know, this is higher in Black people than white people, hypertension. That's used all the time in the US. No, there's a ton of data on allostatic load. There's a ton of data on what happens when you don't have adequate food, right? So we pathologize it. And race-based clinical guidelines, which has revolutionized my learning as a clinician, things I took for granted for decades of practice. This is one example to highlight for you, that in the US, for example, marginalized communities have very high rates of chronic kidney disease. And it historically was like, oh, they're just hypertensive, they have poorly controlled diabetes, they don't take their meds, et cetera, et cetera, et cetera. And what they found is that when we measure kidney function, we can't go to the kidney and get the blood out and say this is how you're filtering, but we use these common estimate equations. And these are the two most common. And they have a race multiplicative coefficient that is applied for Black patients, including in this country, by the way. There's a Black coefficient assigned to the estimate of GFR. And that racial modifier was based actually on phenotype. When they go back, it was predicated on this model that Black people had more muscle mass, right? Again, all that stuff from the either slavery, colonial perspective of races being different. And what it did is you just say, well, okay, let's just take it out. You know, how bad could it be? Whatever, you know? No, here's the disparity gap. If you take out that race factor, which is species in the EGFR equation, look at this. 1 million more Black adults newly diagnosed with kidney disease. 68,000 will be able to meet nephrology and have a discussion about how they protect their kidneys further. And an additional 37,000 can get access to be put on the transplant list. So imagine this, right? If I can't be eligible to be on a transplant list because of a false unidentification of my kidney function, I have much higher risk of death. So this is why this matters. It's not just about saying, oh, it's just a different number. It's the numbers matter. And this is just one. Look at the guidelines. There are countless more. Some might be used in Ireland and some might be not. Right? Risk calculators for heart mortality, for acute cardiac mortality. The option to allow women to have vaginal birth trials after I've had a prior C-section. Risk scores for osteoporosis. Pulmonary function tests. The pulmonary function test data are terrifying. That on the machines in many, many countries, there was a race button that would be pushed to give the pulmonary function test for Black people. And it was predicated in, that was built in the concept of slavery, where it said, oh, if Black people have more lung volume, then they make better slaves, right? I mean, this stuff is embedded in what we use and do every day. And so how does one unteach that? How do we look at what we're doing and using and change that? We talked a little bit about structural competency, being aware. How do our learners become aware of the forces that influence health outcomes? You know, there's so many diagrams that talk about healthcare and sort of health, sort of going to a doctor accounts for like sometimes like 10% of the outcomes. The rest is all this other stuff: housing, education, good food, early dental care. I mean, all that has much bigger impact on outcomes. So we're not teaching the structural determinants. We don't talk about how clinical interactions can be enhanced. We don't talk about how do we re-articulate cultural presentations into structural, as opposed to like, well, Black people don't do this, or traveler people don't do this. No, what are the structural barriers? And then how do we reimagine and help our learners really build and consider new ways of doing things, right? That's the next generation, that's the future. And they will change things if we leverage their learning and tools around it. There are ways to apply that structural competency to the epidemiologic patterns of disease. How do you integrate research when they're doing journal club and we're teaching them to critically think at the literature? How do we bring in research that talks about the structural determinants of health? In journal club, when articles include their table 1 analysis by race, just put in a couple of facilitator questions. What might race be used as a proxy for here? Do you think it's a biological marker or a structural contributor to disease? Little things when we're doing what we're doing, we can really change how people learn and how people think about this. There's the hidden curriculum, right? Defined as a set of influences that function at the level of the organizational structure. They're the implicit rules about how to survive, how to thrive, what are the customs and rituals, right? How do I take tests? Hey, these are the best study materials, these are kind of useless, don't pay attention to that class. This is how you can do better on the test. Don't focus on this, focus on this. It's not so hidden for students, right? But we don't know what it is. We don't know all the parts of it. And it's network-based. I have a really strong social network. We have a group that's, oh, we got these upper class people telling us what to do. But minoritized individuals don't have that. They're not part of those networks. They're alienated. So they're not even hearing about the ways to be successful in the formal curriculum because they're not part of the informal. Pedagogy, that second bucket there. You know, build in, as teachers, build in self-reflection exercises. Ask our students, so what might be the privileges we all share when we're discussing this case? How do we benefit from societal structures when we look at this question? Because the conscious acknowledgement by teachers will help model for students what we want from them. To include literature and texts and film, to contextualize and center learning, the inclusion of the arts in medical education is extraordinarily powerful. Visits to museums, looking at images, like beautiful art that might show how people are treated, right? The Marion Sims, who was this very famous gynecologist in the US, who conducted all his research on Black women without any anesthesia. There are pieces of art, and we just put the art up, and it shows Marion Sims and this Black woman lying unclothed on the table. And we just ask what people observe. And some people know the story, some people don't. And then you can go back in the story. So what are the images and films that can bring to life the experiences of others? And then how do you make structural determinants tangible? What are structural determinants? Where do they come from? Who benefits? Who suffers? What can be done? It's about questions. It's not about having the right answer. It's about stimulating questions. And as in pedagogy, that can be the most wonderful because it doesn't mean you have to know everything. Try to facilitate an inclusive learning environment. How do we build those skills in our faculty? How do we encourage them to be encouraging versus threatening? No one's saying reduce your standards of quality and expectation of our students, but how does one encourage versus threaten? How does one model being open-minded and reflective? And the fact that we talk about it in medicine all the time. We're lifelong learners. How do we show that to our students in this bucket? Do we? Build in opportunities for students to connect with us positively and connect with the community. Field experiences. Rena introduced me to the APCC, the Primary Care Collaborative. Do our learners go and see the models that are being built that are centered around community engagement? How might we encourage our learners to do perspective-taking exercises? I'm never going to walk in your shoes identically, but how might I think through what that feels like? And how do we have shared identity and diverse identity exploration of similarities and differences? And just as much as we talk about, you know, they need to come to the classroom, they need to dissect for 45 hours, we need to build in pedagogical experiences that allow for this broad-taking, breathtaking experiences that will actually change their views. There's more to the literature on this. It's about standardizing the language. These are all very helpful tips that can be really applied. Appropriately contextualizing differences in disease burden. This is a sort of second table to that first table that sort of identified the areas. And thinking about how do you generate and impart evidence-based medical knowledge when it comes to race? Because this generation, we want them to say, it's not okay that I'm seeing Black maternal mortality rates or traveler rates related to this outcome as acceptably disparate. We want them to say, this has been going on for 50 years. It is no longer acceptable. And I'm going to design studies to change that, or interventions. And so we are pushing to move from race-based to race-conscious. This idea that race at the bottom is defined as a social construct, a power construct, that the effects of structural racism get analyzed, that we think about the consequences of racism on the health, teach about it, and that we provide in clinical practice ways to overcome structural barriers to health. And Ireland has a strong model of interdisciplinary team participation in patient care, much more than the US, where it's all the doctor at the head, for the concept of social work and physical therapy, occupational therapy. You know, that model is exactly what you need when you're thinking about just the determinants of health. In terms of assessment bucket, we're still in the first category, Aaron. There's a lot to do. Assessment helps us as educators know where learners are. It helps provide learners with the directions for their future learning. It provides an evidence to the learner about how they're doing through scores and or narrative material. So assessment is filled with bias. There are study after study about gender bias in assessment. This was a study looking at the impact of gender on assessment of postgraduate trainees in a variety of fields. 5 of the 9 studies showed differences in outcomes attributed to gender after correcting for various other things in their performance measures, in their narratives, and in the traits ascribed to them. It's incredible across all these fields. There is gender bias across thousands of evaluations by hundreds of faculty. At year 3, which in medicine is the sort of last part of your postgraduate training, you're ready to be launched into unsupervised practice. The interaction between gender of resident and postgraduate training was significant across all competency areas. Male faculty rated male end-of-year residents higher than all female residents in all competencies. And female resident scores for competencies peak in the year before they're considered ready for graduation. And then just plateau, completely different than men, right? So assessment, there's racial and gender, so we add intersectionality. This was looking at the clinical year for students, 1,000 students, 6,500 assessments in 4 of 6 clerkships. The grading disparities all favored white students. And in their summary, which is the summary letter that's written for students when they're going to go for residency, look at who was described as outstanding. Incredible. Incredible. 71% of white students, 13% of non-underrepresented minorities, 3%. 3%. What do we know about test scores? In the US and actually across the world, minoritized students tend to receive lower scores on standardized exams. In the US, it's all the standardized gateway exams before health professional education, through medical education, and outside of it. And these are clearly representative of the long-term consequences of structural racism, from early childhood education to having the economic supports for tutoring and test prep, to housing, to family caregiving responsibilities. Standardized exams have consistently shown disparities for those who are minoritized. And yet standardized test performance is overweighted in assessment decisions. It's not to say that other assessments do not have biases. There's rater bias when I observe someone. There's familiarity bias. Oh my God, I know Rena from like when she was a child. She's an awesome medical student. Sampling bias. I'm just going to evaluate Miriam today. You know what? I don't care if it's a bad day for her. She's getting a grade today, but I'm not sampling enough of the time with her. But why does that all matter? It matters because assessment decisions have impact on future prospects. This is a brilliant set of work from a team at UCSF that's called the amplification cascade. And it's this concept when they did the study that these students would have 1/10 of 1 point, minority students would have 1/10 of 1 point difference on their score for their core clinical rotation, 1/10 of 1 point. It would lead to 40% less honors, which was the top grade in that clerkship. And clerkship honors were used to determine their induction into the National Medical Honor Society, which is called AOA in America, which was used by residency programs to determine if they were going to interview. 1/10 of 1 point led to this massive, what they call an amplification cascade. 1/10 of 1 point. So Miriam sees me today. She's a clerkship director. She counts up all my scores. She rounds it. 1/10 of 1 point now leads to this. Right? So that amplification cascade is why assessment in math matters. There are components of equity that the curriculum design team can look at. There's intrinsic equity, contextual equity, instrumental equity. I will not go through them all, but there are ways of looking at the criteria for assessment tools. Great articles to look at on this. and making sure that we look at those when we build a new assessment model for our new curriculum. It's also important to have clear criteria for competency-based assessment. Excuse me, things that are observable and things that are not. How are supervising faculty trained? Do they get bias training? Do they reflect on their own bias? Do they understand what's called the amplification cascade? How do we prioritize assessment for learning? Multiple formative experiences with tight loops of feedback so that the learner can build their skills. Having our faculty co-create learning goals with our students. So this is how you do this formative assessment. Let's think about the next one. What might you want to work on before we meet again? Right? Build it together so that they're motivated. And as faculty, it is important for us to know who our learners are, who they are, their learning goals, being open about ourselves, explaining our expectations, scaffolding assessments, multiple observations with less individual weight and lower stakes. And then the concept of name, reframe, and check-in, which is a really cool model. We understand that cognitive bias permeates learner assessment. None of us can be trained out of it. But there are simple ways as an assessor that we acknowledge bias, we explain what our perspective of observation is, and we invite our learner to check in and collaborate with us, right? And these are the low stakes formative ways allows our learner to not be petrified of meeting an assessor, but to understand they are helping me to get to my next goal. And as faculty, focusing on observable behaviors using competency-based language. Remember to look at your documentation for language because it promotes stereotypes. And then helping students achieve their learning goals. So this is that big bucket. There's a lot you can do as programs. I will give you all these slides. I want to make sure I am conscious of time. Wow, look at this. It just goes on and on and on. Inequitable attainment gaps that Aaron spoke about, realizing that there's this impact of structural bias, that equity is the driver, thinking about how you collaborate with partners that are here that are doing great work. And then how do you weight the contribution of tests? And how do you think about that equity-focused way of student support and resources, given people are coming in with very different experiences? How do we provide an equity framework for students to benefit from what Trinity has to offer? Faculty and staff, the other bucket, increasing representation and racial justice training were the two areas that Aaron and Miriam's group spent a lot of time on. How are we doing? 15? Oh my God, including discussion. Okay, faculty and staff. What's our responsibility as teachers, researchers, and administration? Role modeling good practice, thinking about the content pedagogical approaches I spoke to, and our participation in professional development and prioritizing this as much as we prioritize our clinical professional development. For those who are involved in research, think about how you bring together students, staff, and faculty. How do you attribute resources to stimulate scholarship in this area? How do you co-produce research with minoritized learners? And then there are incredible collaborators here that I've learned about. How do we build collaborations across the schools here with the Racial and Ethnic Equality Working Group, the Immigrant Council? I mean, there's just incredible opportunity for us to center the research work. And as administrators, we're all administrating this big program here. Gather data on representation. Think about our human resource policies and practices. How are people promoted? How do we build coaching, mentoring programs for minoritized individuals? And then how do we think about short, medium, and long-term goals, thinking about who teaches our students, who's presented to our students, and an accountability structure around it. There are lots of things to learn about, and there are lots of skill-based sessions that can be part of this kind of professional development as we all learn. It's a new area of learning for many people. Policies and practices is an important bucket, concepts of how people report, support for the victimized, as Dr. Mullen was talking about, racial justice training. Briefly, this concept of mistreatment and bias, there needs to be anonymous and confidential options that are easily available. And there needs to be a policy on when students encounter the racist and biased patient with a clear protocol for learners, accountability structure, and a training structure. The Association of American Colleges provides what they define mistreatment for our learners. It's assessed across all trainees. There are 17 behaviors that constitute mistreatment toward learners. And they are presented by school. You get your school data annually, and you can compare yourself nationally to other schools. But we do a lot of internal data after every course, clinical rotation. Everything is presented to leadership. We use it to guide training. We have a student mistreatment representatives, and we have a third-party values line that is completely anonymous, not staffed by the hospital or school, for students to be able to report. There's decanal leadership level committees that look at this. We have town halls and class meetings. If we don't make this a huge priority, it's going to continue to happen. We, a lot of options for students, including mental health support that is 24/7. And this is a great piece of work that I think at some point would be worth looking at. The biased patient, there's some great protocols online about how to actually build a policy for dealing with a biased patient and having a policy that's different for trainees. So maybe the hospital is not ready to have a big one, but for trainees who are there, there's a way to do it. Lots more, my goodness, I'm just endless. Training, international learners, really this idea that you have a very strong population that needs to be attended to. Procedures around quality improvement, student feedback, and oh my God, I feel like we have so much to learn from your report, Aaron. Fostering open dialogue, preparing, that was a big one, preparing students for clinical placement and acknowledging the work of minoritized individuals. You know, students experience a lot of microaggressions, and the effect on people is not micro, it's cumulative and horrible. And so making sure that you offer small group experiences, how does one have dialogue? How does it then create a formal framework for student engagement? I know Lena has been thinking a lot about this idea about how do we bring people from minoritized backgrounds to be able to participate, but also having strong allies. And I've given you a few recommendations on allyship training because I think we could all do it. I know talked about this, the fact that we cannot leave this to marginalized people. We have to be all in. And what does allyship training look like? What does upstander training look like? Again, easily available that we could do for all of our trainees and faculty and staff. And then this idea about when you send people into clinical placements where things are very difficult, the school needs to own that it's zero tolerance toward our learners, that we have these reporting non-retaliation programs, and we have a plan for how the racist or biased patient will not be taken care of by a learner. Teaching students to stand up and including opportunities for learners to meet clinical site leaders because they don't even know the hospital president, they don't know the hospital leader, they don't know what to do when they're at a clinical site. And this final idea of really should not be minimized is how does one build a community for those who are giving so much? It needs to be our problem, all of ours. We have come up with different ways institutionally of offering credit-bearing experiences, graduation awards, financial contribution for those minoritized learners, and actually using it to amplify when we're thinking about their next steps in training, how to amplify what they've given so graciously to us so that they are recognized in the next stage of their careers. So where do we start in all this? It sounds insane, but I think that the reports have given an opportunity to look at the goals and for a community of people and leadership to come together and just prioritize the first one. Which one is going to be our first one that we're going to work on? How do we break it up into small units of work and have an action plan with a timeline for one thing? How will we know that we have met that action plan and outline to measure the impact? And we are going to pick something that's a small win because that will motivate us for the next step. And realize that coalitions of people who are interested and committed and allies will be the reason for success here. So this is insanely fast, I'm so sorry. All the slides will be available and we are happy to, of course. So then promote from New York.
Thank you very much. Thank you so much.
I didn't give you too much work.
Thanks to all three speakers. And yes, sorry for putting you under a little bit of pressure there, Rena, but I think you were well up to it. And not your first rodeo in the market. But yeah, obviously a lot to think about. Yeah, we'll take a couple of questions. I don't know if you can do a gallery view maybe instead there. Yeah, and we'd be happy to take a couple of questions. Who are there? Hand up there.
Humor did, it's gone again.
Yeah, I'm going to ask a quick question in case before because I don't see any hands up there, and I'm going to actually come back to Phil because interesting as it is the work of the working group with yourself and Lorraine. I mean, I'm just wondering. I don't want to talk for Aaron. there, but I do feel that sometimes the clinical stuff, you said everybody's represented except maybe some auxiliary workers. I challenge that a little bit and say maybe the clinical areas are not. It's a really tough one because we don't have control over all of the staff and the people that are students. I mean, we're just talking about students now that they interact with. And as Aaron brought up and Rena also illustrated so well, they face some really challenging situations out there on, be it in a pharmacy over the counter or be it in a hospital or a clinic or whatever. And I'm just wondering, do you think the group is going to be able to tackle that as well?
That's interesting because there were pharmacy students and other health sciences students who took part in the focus groups. And I think they targeted it as a place to actually have their voices heard. So they were aware of the focus groups. They knew they wanted to get out what was happening in health sciences. I think probably what we haven't done is connect Aaron's report with the fact that we should have a representative from health sciences sitting on the group. The problem is we should have a health sciences rep or their nominee. However, I'm not sure whether they've actually engaged. So we could bring those issues to the group and the representative on the group should be able then to feed them back into health sciences at a senior level. But we've had low engagement, let's say, from the deans of faculties or their nominees. And interestingly, the majority of people who continue to engage are those who continue to be racialized and marginalized. So while in the early days everybody was attending and engaging, it has dropped off. And so it's left to the people who feel they have something to benefit and that they need to continue to drive it forward. But we haven't had a lot of engagement.
And there again, I think there's an interesting parallel with Athena Swan, where I think maybe they're just a little further ahead on the curve, where I think they've managed a greater level of engagement. So I guess maybe it would be, as you pointed out, keeping up or catching up with Athena Swan, you know, with kind of the gender agenda. It's I suppose it's somewhere to aim to a little
I think
bit.
we're moving into an area of compliance where it won't be a choice.
Yeah.
You know, everybody will engage.
And I have a quick question for Aaron as well, because Rena left us there with a thought, and I was she articulated well. If there was one go out of all of that, you have to start, as they say, you know, that journey with the first step and all of that. If there was one goal you think we could start on in terms of, say, the faculty even and or the race and ethnicity working group, what do you think the most important thing is that we should start with?
Good question. I remember from the convening that there was a very strong consensus that what the students want is curriculum reform, a complete sort of rehaul of the curriculum and how to sort of decolonize the whole curriculum and how to embed racial justice across modules, across teaching sessions, across placements. And that's not a one-day job, but that's what the students want. And I think that's a direction we should definitely look at. And, you know, I'm just a conduit here, you know, for the students who were at the forum. Yeah, so I suppose that's one thing that came through really strongly in the forum for your consideration, I suppose. And in terms of how to take this forward, I think another really important thing to think about, and maybe Rena can speak to this, which is the fact that there hasn't been a lot of diversity in senior leadership in faculty health sciences, and there aren't a lot of senior academics who are from minoritized ethnic backgrounds. And if we really want to take this forward, then, you know, is it going to be a white person? And if that's the case, you know, how are we going to ensure that this project, very much a grassroots racial justice project developed by students in collaboration with staff, this sort of emotional and intellectual labor, and how we can make sure that's not being capitalized, and you know, how to make sure we're not actually structurally replicating the very thing that we're trying to tackle. in the process of tackling it, if that makes sense. So it's always in the process of, I think this is the third time I'm saying this week, working within the system, but also against the system. And how do we do that? Yeah.
No, thank you. That's an answer to, you had a couple of priorities there, and I think we'll probably be talking again, to be honest with you. Any other, I don't want to keep going on here myself. Any other questions from either in the room, comments, or yeah?
So thank you for the three speakers. One, I mean, it's work that needs to be done across multiple levels. But I was wondering, might it not be advantageous perhaps to focus it in one particular area as a demonstration of what can be accomplished for the rest of the faculty or the school and so on and so forth. We're working, Trinity or any university has so many different departments, faculties, and so on and so forth. There's just so much energy and time. And perhaps it might be, it'll be slower at the beginning, but over the long term, seeing what can be accomplished in one particular area that might provide the example for others to follow. It's just, I don't know if anybody has tried anything like that at any university or institute.
I mean, I will say that one of the, that's very good question, because it can also serve as a motivating factor to other faculties and other groups. I will say that, I've been impressed that I don't do the Western Trinity, but I've been lucky to come here and, and I feel like having Brian listen and having this idea that we have dedicated students and colleagues and a community of experts to come together in this way is that first step in acknowledging it. And it might be, I would hope that it will be in the health sciences, because we can serve as that model, because lives depend on it. That's what's different. I feel like, and maybe I'm biased in this idea, but this idea that when you're talking about literature, so, another area, plus patients' lives depend on it. What better driver than for us to be the first school within the health professions, whichever that is, to pick a project that we're going to work on, tackle it, even if it's complex and gnarly and hard, because patients' lives depend on it. That's why. That's the biggest driver for my desire for it to be in health profession.
I think that's a really good point, and I think if you could showcase it, but I think it's unfortunate that we have to, that's the hook. We should, I mean, we need a hook, but I mean, it's relevant and useful without a hook. I mean, but if it's got a broader perimeter, I think so, but also I think the centrality of the patient, you got it from, there's so many kind of ways it comes from when it comes to teaching, but the patient in the middle and the clinical sides, I think health sciences would be a very, very good kind of place to start. But I was just, in terms of Trinity, I was just conscious of two things mentioned, the whole Barclay and legacy thing. I mean, that's fine at structural level now, and it's got impetus because politically, wouldn't it be wonderful if we could look at the colonial or the colonization of the curriculum, for example, in medical education, at a different level, but mirroring what's going on in terms of the wider discourse. I think that would be an interesting kind of link. And the other point I was just wondering here is, like, the intersectionality piece is really, really important for me. And I got the unofficial title of intersectional researcher in medicine, which is a very lonely place, because in terms of I relish it, but it's just to get by. So intersectionality at the moment is a variable in a data set. That these are men, these are female, these are black, and I know that has to happen. But just to bring the thoughts and the fact that this is so similar to gender, and I just think the Athena Swan has gotten official legs because there is a bronze award or a silver award at the end of it, not necessarily because it's the right thing to do. It might be the right thing to do, but again, it's become institutionalized as something that needs to be. So if that's one route to get things evidenced, maybe that's a good route to follow, but it doesn't mean it's all sorted either, in my opinion. But I just think in terms of taking Aaron's point that came from the group, and it was a pleasure to work with Aaron and everybody on this, and I as an ally, if I am, I guess, in this context, is the curriculum reform, and potentially, and I think obviously with Rena here and her long-standing medical education, and obviously, Phil and all the other people, I mean, health sciences seems to be a place maybe we could make a little pilot.
Yeah, absolutely. You know, I think my interpretation of the Athena Swan is I think it maybe, I'll be honest with you, I think it started out
Yes,
as a box you had to tick, but actually I think it reached a tipping point,
yes.
certainly that I have seen, where people eventually at some point just said, no, this is actually a really good idea, this is what we should be doing, and it doesn't need convincing people anymore.
But I think it has to get to the obstacle stage.
Yeah, but
We have to get
maybe is that push, and
Yeah.
maybe in the case of the health sciences, maybe it's patient care, or maybe, you know, it's decolonizing the curriculum. Which kind of, it sort of takes it out of the challenging people too much, and that's my other question, is it challenging enough for people? You know, is it too easy to talk about, you know, it's about the patient, it's about the historical legacy, is that?
That's what I was talking about, the hook.
It's a hook, admittedly, but is it also maybe not challenging people enough? I don't know.
I defer to the people, you know, I don't know.
I certainly don't. Can I just say, in terms of your saying going beyond the box ticking exercise, would you mind sending an email to the School of Nursing and Midwifery? Because I do feel, from my experiences that it is still that it's an elective, and my contract's a year-on-year basis, you know, and everything that's been said here is like it really resonates. With so much material, there's loads to add, you know, or to so many questions here. But the first thing is kind of, well, to know your learner, for example, you know, so I started off by saying, obviously I'm white, so I have a white privilege, and also male, so there's male privilege there, and just explain where I'm coming from. So why is a white male delivering this module on theories of race and ethnicity? So immediately coming to this kind of an approach whereby I'm a student too, so we're here to learn off each other, and that resonates, and all of a sudden the atmosphere kind of relaxes, because I think it's pretty much a 70 to 80% say minority student group. This year about 55 students, you know. I had a question from one student who asked me about reporting on placements, a colleague, you know, so someone that she was kind of under, and there's a racial slur was made. How do I report that, you know? And I had an inadequate response. First of all, is that these institutions, all institutions, whether it's HSE or Trinity College or Gardaí Corner, whatever, protect themselves first and foremost, you know. And that's all my advice at that point was to think about it, try and find an ally, someone that you trust, and maybe share with them and to get support, and then get direction that way. And then the very next day, I got an email from Rena, and she gave me all this, like, thanks so much for your support and encouragement and your help in this. But this, what we would put Aaron's, everybody, so this the next lecture, popped it up, and I got through a few slides, and here you go, guys. You know, we're up to it. It's not the 2007-2012 HSE intercultural guide, which is like so much work was put into that, but it's gone. You know what I mean? And it's not been implemented. Now this, my one question would be, I suppose, do you think it does have legs? That it's not going to be just another attempt to really go into.
I think it will have legs because it's going to be tied to funding.
Right.
So if you don't have it compliant, you don't get your funding, just like it being a small, and I think maybe that's part of the impetus for it being a small as well. Once you tie, like, genuinely believe in sanctions and tying everything to funding, because I don't believe in goodwill, because I think, as Aaron said, it comes down to the individual person who is interested in bringing about change. So then you don't get the structural change, you don't get the systemic change. And the institutional response is, oh, that's very good if that's what you're into, go ahead with it, but nothing else happens. But I think when you force systemic change by tying it to funding and saying, if you don't comply, and if you're not in compliance, and if we don't see that it's a genuine move, you know, because we already have the legislation, you know, the Public Sector Act or Service Act of 2014 says there has to be protection of human rights, that has to be a program of policy, and that has to be, that's not the third one, and to avoid discrimination. They're already legislated for, but again, it's what comes back to what's in the presentation. the policies are all there, but nobody sees them being implemented.
Yeah.
Because the people who need to implement them are generally not effective.
Yeah.
Either.
And that's like, that was my
Mhm.
point, I wasn't having a go with the people
Yeah,
on the
yeah.
group. My point is that it's an order of magnitude more difficult
Mhm.
out in the health service even, like, you know, like the public, because we don't have that, sanction against them of financially or otherwise, you know. Our students interact with a lot of people who aren't employees of the university, let alone the public, you know, and that just makes it even that one more difficult. That's kind of, our reach is limited, and that's why I was very interested, definitely going to come back and look at your material on, you know, difficult patient situations.
Because you're right, we have these contractual responsibilities when we don't own this hospital.
Yeah,
So how do we say, well, we can't tell you what you do with your people,
Yeah.
but we can tell you what our learners will not tolerate, and we as a school will let them experience. And we have to do it that way, we have to do it from the school learner perspective as opposed to controlling your employees. You're right.
yeah, it's.
Can I just ask maybe a fairly basic question, but it keeps coming up about the lack of diversity, say, in our leadership and in when we're all trying as an organization to make these changes, but the reality is we don't have a huge diversity in our staff body. So how do we, in practical terms, progress with being inclusive without then some of what Rena would have spoken about in other sessions as well, is about that toll on the minority, whether they be students or staff. They can't be expected to lead the charge on everything themselves. They can't be expected to be on every committee and every selection panel. So for the stage of our development as an organization, where we are now and our staff profile, how do we manage that and in a practical kind of way?
The director of HR sits on the race ethnicity working group. And we had a meeting during the summer, and she said to me, look, can you please explain to me what this group is actually about? Is it just another talking shop? And after 2 hours, we kind of decided that HR is very much implicated in how the university reproduces its own values, its own beliefs, and its own staff, which tends to be white, possibly middle class, and male in general. So a lot begins at the HR level, and breaking down that sense of homophily, who fits and who doesn't. And in the hiring process, where somebody is sitting on the panel to observe whether there is unconscious bias. But if you have a white male who's sitting on a panel with other white males, and they're trying to observe if these white males are, you know, displaying any unconscious bias, what criteria are they using? What lived experience do they have to understand the nuances of what unconscious bias at a racial level is? So if you're a woman, you might see certain tendencies of unconscious bias. So it's not about prioritizing the lived experience, but it's about knowing that somehow you have to have a greater understanding than just trying to catch somebody else, or that it's going to be overt, or even that there are subtle signs that you'll see. It's so unconscious that maybe you don't even know what the unconscious bias is. So it's how do we start in the process of hiring? Who are we bringing in? Are we looking for people who fit Trinity? Do we go to the same 100 universities? And that's our pool all of the time. And if you don't come from that pool, well, you haven't reached the standard. And yet we still want to bring about change. We want a revolution, but
Sorry, you good.
And I think that's absolutely brilliant, you know, but it's so important not to do the union or the affirmative action, that sort of side. So from my point of view, like with my PhD, my research was basically a learning process for me to understand my own racism, you know. What is that little thing in the background? Start the shedding process, because I don't, not like most people, don't believe you're racist, but yet this is everyday unconscious bias is coming through. So this is like an exercise for me. So it's a personal endeavor, you know, that has wider implications, but yet not to just exclude, you know, just based on these you know, the specific requirements that you're just talking about there. I think it's really.
Yeah, because I was saying, I was speaking as an ally and a privileged person, etc. I think if the burden is not left with people who lived experience, because I don't know you, but I mentioned today, you could, I'm just controversial now, but you could have a non-white woman standing in front of a nursing school, and she might say, I'm a non-white woman and I'm coming through. This man did, because he knows he's learned about those things. So I just think as well, tokenism potential of just getting not nagging, just picking somebody at the wall. So I mean, I think that there is hopefully, until we get to a point that there is a diverse workforce, if that happens over time or through policies to get people in, I think perhaps like this man said, you own yourself and you say it, so you are aware of it and you're making other people aware of it as well. So I don't know if that's a valid comment here. I'm not meant to be critical or anything, but until the point where the HR woman does come on or whatever happens down the line, what about these kind of people? I can't say I have the same credibility as you, but I mean, you know, at least we're aware of things, and I'm just wondering, is that kind of a halfway house kind of until we get, not or a stepping stone until we get diversity of race or ethnicity or whatever into the body of the institution.
We also had a very productive meeting today with HR and the director was here, very sensitive, spoke very meaningfully about how much she and her team have learned from conversations with you and participation. And I actually feel that team is really primed in a very sort of committed way to thinking through things, and their shared experiences, their lived experiences, understanding different identities that they've had and different challenges that they've overcome as a team, you know. So to your question about, you know, how we're going to change it and from where we're going to change it. And part of me thinks, you know, wonderful thing is that there's students in the pipeline, they're going to take a while to get there to leadership. But then in active recruitment for the concept that the heads of schools know in some ways what positions they might be looking for in the next year, to be the champions of diversity. Literally the champions that we are looking for 2 neurologists, I'm making it up, 1 assistant dean in blah, 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 4 curriculum leaders in something. And I, as the dean of this school, am absolutely seeking, you know, a diverse body of, you know, folks and consistently connecting with HR to say, who are you hearing from? Where's the job description gone out? Have we gone beyond the same 100 universities? Who's in the pipeline? I don't want to wait till the final round. We've got 3 people to look at and say, no, go back to the drawing board because I got to staff that program tomorrow. But in that early process, how are we going to reach? Where are we going to reach? Who are we going to consider? What identities? Maybe we don't get all the identities we want in one human, but we get some. But really being aggressive and in a sort of discussion of curriculum reform. Who am I going to advocate for in my budget cycle for the new curriculum or the new whatever from now, so that I get that position sort of approved for her 3 years from now or whatever it is? Because then I'm going to start beginning this conversation about diversity in leadership.
And I'm really sorry to, I think, have to end it at this point. And thank you to everybody who's come today, both physically and also on the Zoom as well. We've been delighted to have you. Thank you especially for Aaron, to Phil, and as well as yourself.
Thank you.
And I think there's a lot to think about. I think we'll have the resources up on the website as Lena will do. Lena, thank you for organizing the whole thing. As ever, lots to think about exactly. And I guess we will. Well, we'll follow up. Maybe we'll have a bit to think about and see what we can do and see if we can work with you.
We're going to try to pull together like an overall report from the 3-day visit, because we have so many different sessions, and then we can kind of get at what outcomes from that.
Rena has worked really hard. It's a pleasure to have you here, and you know, a lot to think about, and I think it's just worked really well together with you know, with what we're doing, and hear about everything that you're involved with as well. So thank you all. Sorry for running a bit late, but I enjoyed the discussion. So take care.
Thanks, everyone.